Good morning, students. Second lecture is traumatic shock for today. The initial step in managing shock in injured patients is to recognize its presence. No laboratory test diagnoses shock. Rather, the initial diagnosis is based on clinical appreciation of the presence of inadequate tissue perfusion and oxygenation. Definition of shock as an abnormality of the circulatory system that results in inadequate organ perfusion and tissue oxygenation also becomes an operative tool for diagnosis and treatment. The second step in the initial management of shock is to identify the probable cause of the shock state. In trauma patients, this process is directly related to the mechanism of injury. Most injured patients in shock have hypovolemia, but they may suffer from cardiogenic, neurogenic, and even septic shock on occasion. In addition, tension pneumothorax can reduce venous return and produce shock. This diagnosis should be considered in patients who may have injuries above the diaphragm. Neurogenic shock results from extensive injury to the central nervous system or spinal cord. For all practical purposes, shock does not result from isolated brain injuries. Patients with spinal cord injury may initially present in shock resulting from both vasodilatation and relative hypovolemia. Septic shock is unusual, but must be considered in patients whose arrival at the emergency facility has been delayed by many hours. The doctor's management responsibilities begin with recognizing the presence of this shock state, and treatment should be initiated simultaneously with the identification of a probable cause. The response to initial treatment, coupled with the findings during the primary and secondary patient surveys, usually provides sufficient information to determine the cause of the shock state. Hemorrhage is the most common cause of shock in the injured patients. Shock pathophysiology. What is shock? And overview of basic cardiac physiology and blood loss pathophysiology is essential to understanding the shock state. Basic cardiac physiology. Cardiac output, which is defined as the volume of blood pumped by the heart per minute, is determined by multiplying the heart rate by the stroke volume. Stroke volume, the amount of blood pumped with each cardiac contraction, is classically determined by the following: preload, myocardial contractility, afterload. Preload, the volume of venous return to the heart, is determined by venous capacitance, volume status, and difference between mean venous systemic pressure and right arterial pressure. This pressure differential determines venous flow. The venous system can be considered a reservoir of capacitance system in which the volume of blood is divided into two components. One component does not contribute to the mean systemic venous pressure and represents the volume of blood that would remain in this capacitance circuit if the pressure in the system were zero. The second, more important, component represents the venous volume that contributes to the mean systemic venous pressure. Nearly 70% of the body's total blood volume is estimated to be located in the venous circuit. The relationship between venous volume and venous pressure describes the compliance of the system. It is this pressure gradient that drives venous flow and therefore the volume of venous return to the heart. Blood loss depletes this component of venous volume and reduces the pressure gradient. As a consequence, venous return is reduced. The volume of venous blood returned to the heart determines myocardial muscle fiber length after ventricular filling at the end of diastole. Muscle fiber length is related to the contractile properties of myocardial muscle according to the Starling's law. Myocardial contractility is the pump that drives the system. Afterload is systemic vascular resistance, or simply stated, the resistance to the forward flow of blood. Blood loss pathophysiology. Early circulatory responses to blood loss are compensatory progressive vasoconstriction of cutaneous muscle, and visceral circulation preserves blood flow to the kidneys, heart, and brain. The response to acute circulating volume depletion associated with injury is an increase in heart rate in an attempt to preserve cardiac output. In most cases, tachycardia is the earliest measurable circulatory sign of shock. Tachycardia. The release of endogenous catecholamines increases peripheral vascular resistance, which in turn increases diastolic blood pressure and reduces pulse pressure, but does little to increase organ perfusion. Other hormones with vasoactive properties are released into the circulation during shock, including histamine, bradykinin, beta endorphins, and the cascade of prostanoids and other cytokines. These substances have profound effects on the microcirculation and vascular permeability. Venous return in early hemorrhagic shock is preserved to some degree by the compensatory mechanism of contraction of the volume of blood in the venous system, which does not contribute to mean systemic venous pressure. However, this compensatory mechanism is limited. The most effective method of restoring adequate cardiac output and organ perfusion is to restore venous return to normal by volume depletion. At the cellular level, inadequately perfused and oxygenated cells are deprived of essential substrates for normal aerobic metabolism and energy production. Initially, compensation occurs by shifting to anaerobic metabolism, which results in the formation of lactic acid and the development of metabolic acidosis. If shock is prolonged and substrate delivery for the generation of adenosine triphosphate is inadequate, the cellular membrane loses an ability to maintain its integrity and the normal electrical gradient is lost. Swelling of the endoplasmic reticulum is the first ultrastructural evidence of cellular hypoxia. Mitochondrial damage soon follows. Lysosomes rupture and release enzymes that digest other intracellular structures elements. Sodium and water enter the cell and cellular swelling occurs. Intracellular calcium deposition also occurs. If the process is not reversed, progressive cellular damage, additional tissue swelling, and cellular death occur. This process compounds the impact of blood loss in hyperperfusion. The administration of a sufficient quantity of isotonic electrolyte solutions helps combat this process. Patient treatment is directed toward reversing the shock state by providing adequate oxygenation, ventilation, and appropriate fluid resuscitation. Resuscitation may be accompanied by a systemic arteries marked increase in interstitial edema, which is caused by reperfusion injury to the capillary interstitial membrane. As a result, larger volumes of fluid may be required for resuscitation than initially anticipated. The initial treatment of shock is directed toward restoring cellular and organ perfusion with adequately oxygenated blood. Control of hemorrhage and restoration of adequate circulating volume are the goals of treatment of hemorrhagic shock. With the possible exception of penetrating trauma to the torso without head injury, a volemia should be maintained. Vasopressors are contraindicated for the treatment of hemorrhagic shock because they worsen tissue perfusion. Frequent monitoring of the patient's indices of perfusion is necessary to evaluate the response to therapy and detect deterioration in patient's condition as early as possible. Most injured patients who are in hypovolemic shock require early surgical intervention to reverse the shock state. Presence of shock in an injured patient warrants the immediate involvement of a surgeon. Initial patient assessment. Optimally, doctors will recognize the shock state during the initial patient assessment. To do so, it's important to be familiar with the clinical differentiation of the causes of shock, chiefly hemorrhagic and non-hemorrhagic. Recognition of shock. How we can see a patient in shock? Profound circulatory shock evidenced by hemodynamic collapse with inadequate perfusion of the skin, kidney, and central nervous system is simple to recognize. However, after the airway and adequate ventilation have been ensured, careful evaluation of patient's circulatory status is necessary to identify early manifestations of shock, including tachycardia and cutaneous vasoconstriction. Relying solely on systolic blood pressure as an indicator of shock may result in delayed recognition of the shock state. Compensatory mechanism may preclude a measurable fall in systolic pressure until up to 30% of the patient blood volume is lost. Specific attention should be directed to pulse rate, respiratory rate, skin circulation, and pulse pressure. Pulse pressure is the difference between systolic and diastolic pressure. Tachycardia and cutaneous vasoconstriction are the typical early physiological responses to volume loss in most adults. Any injured patient who is cool and has tachycardia is considered to be in shock until proven otherwise. Occasionally, a normal heart rate or even bradycardia is associated with an acute reduction of blood volume. Other indices of perfusion must be monitored in these situations. Normal heart rate varies with age. Tachycardia is present when the heart rate is greater than 160 in an infant, 140 in a preschool age child, 120 in children from school age to puberty, and about 100 in an adult. Elderly patients may not exhibit tachycardia because of their limited cardiac response to catecholamine situations or the concurrent use of medications such as beta-adrenergic blocking agents. The ability of the body to increase the heart rate also may be limited by the presence of a pacemaker. Narrowed pulse pressure suggests significant blood loss and involvement of compensatory mechanisms. Laboratory values for hematocrit or hemoglobin concentration are unreliable for estimating acute blood loss and inappropriate for diagnosis shock. Massive blood loss may produce only minimal acute decrease in the hematocrit or hemoglobin concentration. Thus, a very low hematocrit value obtained shortly after injury suggests massive blood loss or pre-existing anemia, whereas a normal hematocrit does not exclude significant blood loss. Base deficit and or lactate levels may be useful in determining the presence and severity of shock. Serial measurements of these parameters may be used to monitor a patient's response to therapy. Clinical differentiation of cause of shock. What is the cause of shock state? Shock in a trauma patient is classified as hemorrhagic or non-hemorrhagic. Patient with injuries above the diaphragm may have evidence of inadequate organ perfusion due to poor cardiac performance from blunt myocardial injury, cardiac tamponade, or tension pneumothorax that produces inadequate venous return preload. High index of suspicion and careful observation of the patient's response to initial treatment will enable the doctor to recognize and manage all forms of shock. Initial determination of this cause of shock depends on taking an appropriate history and performing a careful physical examination. Selected additional tests such as monitoring central venous pressure and obtaining data from a pulmonary artery catheter, chest and or pelvic X-ray examinations, and ultrasonography may provide confirmatory evidence for the cause of shock state but should not delay aggressive volume restoration. Hemorrhagic shock. Hemorrhage is the most common cause of shock after injury, and virtually all patients with multiple injuries have an demand of hypovolemia. In addition, most non-hemorrhagic shock states respond partially or briefly to volume resuscitation. Therefore, signs of shock are present. Treatment usually is instituted as if the patient is hypovolemic. However, as treatment is instituted, it's important to identify the small number of patients who are shock has a different cause. Secondary conditions such as cardiac tamponade, tension pneumothorax, spinal cord injury, or blunt cardiac injury which complicates hypovolemic hemorrhagic shock. The primary focus in hemorrhagic shock is to identify and stop hemorrhage promptly. Non-hemorrhagic shock. Non-hemorrhagic shock includes cardiogenic shock, cardiac tamponade, tension pneumothorax, neurogenic shock, and septic shock. Cardiogenic shock. Myocardial dysfunction may be caused by blunt cardiac injury, cardiac tamponade, on an air embolism, or rarely a myocardial infarction associated with the patient's injury. Blunt cardiac injury should be suspected when the mechanism of injury to the thorax is rapid deceleration. All patients with blunt thoracic trauma need constant electrocardiographic monitoring to detect injury patterns and dysrhythmias. Blood creatine kinase isoenzymes and specific isotope studies of the myocardium rarely assist the doctor in diagnosis of or treating patients in the emergency department. Echocardiography may be useful in the diagnosis of tamponade and vascular rupture, but it's often not critical or immediately available in the emergency department. Focused assessment sonography in trauma in the emergency department can identify pericardial fluid and the likelihood of cardiac tamponade as the cause of shock. Blunt cardiac injury may be an indicated for early CVP monitoring to guide fluid resuscitation in this situation. Cardiac tamponade is most commonly identified in penetrating thoracic trauma, but it may occur as a result of blunt injury to the thorax. Tachycardia, muffled heart sounds, and dilated and engorged neck veins with hypotension resistant to fluid therapy suggest cardiac tamponade. However, the absence of these classic findings does not exclude the presence of this condition. Tension pneumothorax may mimic cardiac tamponade, but it's differentiated from the latter condition by the findings of absent breath sounds and the hypersonant percussion not over the affected hemithorax. Appropriate placement of a needle into the pleural space in the case of tension pneumothorax temporarily relieves this life-threatening condition. Cardiac tamponade is best managed by thoracotomy. Pericardiocentesis may be used as a temporizing maneuver when thoracotomy is not an available option. Next is tension pneumothorax. Tension pneumothorax is a true surgical emergency that requires immediate diagnosis and treatment. It develops when air enters the pleural space, but a flap valve mechanism prevents its escape. Intrapleural pressure rises, causing total lung collapse and a shift of the mediastinum to the opposite side with a subsequent impairment of venous return and fall in cardiac output. The presence of acute respiratory distress, subcutaneous emphysema, absent breath sounds, hyperresonance to percussion, and tracheal shift supports the diagnosis and warrants immediate thoracic decompression without waiting for X-ray confirmation of the diagnosis. Hemorrhagic shock and injured patients pitfalls. What pitfalls we can see? Missing tension pneumothorax. Assuming there is only one cause of shock, young healthy patients may have compensation for an extended period and then crash quickly. Next is neurogenic shock. Isolated intracranial injuries do not cause shock. The presence of shock in a patient with a head injury necessitates a search for a cause other than an intracranial injury. Spinal cord injury may produce hypotension due to loss of sympathetic tone. Loss of sympathetic tone compounds the physiologic effects of hypovolemia, and hypovolemia compounds the physiologic effects of sympathetic denervation. The classic picture of neurogenic shock is hypotension without tachycardia or cutaneous vasoconstriction. Narrowed pulse pressure is not seen in neurogenic shock. Patients who have sustained a spinal injury often have concurrent torsotrauma. Therefore, patients with unknown or suspected neurogenic shock should be treated initially for hypovolemia. The failure of fluid resuscitation to restore organ perfusion suggests either continuing hemorrhagic or neurogenic shock. CVP monitoring may be helpful in managing this sometimes complex problem. Septic shock. Shock due to infection immediately after injury is uncommon. However, if a patient's arrival at the emergency facility is delayed for several hours, it could occur. Septic shock may occur in patients with penetrating abdominal injuries and contamination of the peritoneal cavity by intestinal contents. Patients with sepsis who also have hypotension and are afebrile are clinically difficult to distinguish from those in hypovolemic shock, as both groups may manifest tachycardia, cutaneous vasoconstriction, impaired urinary output, decreased systolic pressure, and narrow pulse pressure. Patients with early septic shock may have a normal circulating volume, modest tachycardia, warm pink skin, systolic pressure near normal, and wide pulse pressure. Hemorrhagic shock and injuries patients. Hemorrhage is the most common cause of shock in trauma patients. The trauma patient's response to blood loss is made more complex by shifts of the fluids among the fluid compartments in the body, particularly in the extracellular fluid compartment. The classic response to blood loss must be considered in the context of fluid shift associated with soft tissue injury. In addition, the changes associated with severe prolonged shock and pathophysiologic results of resuscitation and reperfusion must also be considered as previously discussed. Definition of hemorrhage. Hemorrhage is defined as an acute loss of circulating blood volume. Although there is considerable variability, the normal adult blood volume is approximately 7% of body weight. For example, a 70-kilo male has a circulating blood volume of approximately 5 liters. The blood volume of obese adults is estimated based on their ideal body weight, because calculation based on actual weight may result in significant overestimation. The blood volume for a child is calculated as 8 to 9 of body weight, 8 to 9% of body weight. Direct effects of hemorrhage. The classification of hemorrhage into 4 classes based on clinical signs is a useful tool for estimating the percentage of acute blood loss. These changes represent a continuum or ongoing hemorrhage and guide initial therapy. Volume replacement is guided by the patient's response to initial therapy, not solely by the initial classification. This classification system is useful in emphasizing the early signs and pathophysiology of the shock state. Class 1. Hemorrhage is exemplified by the condition of an individual who has donated a unit of blood. Class 2 is uncomplicated hemorrhage for which crystalloid fluid resuscitation is required. Class 3 is a complicated hemorrhagic state in which at least crystalloid infusion is required and perhaps also blood replacement. Class 4 hemorrhage is considered an preterminal event, and unless very aggressive measures are taken, the patients will die within minutes. Several confounding factors profoundly alter the classic hemodynamic response to an acute loss of circulating blood volume, and this must be promptly recognized by all individuals involved in the initial assessment and resuscitation of injured patients who are at risk for hemorrhagic shock. These factors include patient age, severity of injury with special attention to type and anatomic location of injury, time lapse between injury and initiation of treatment, pre-hospital fluid therapy and application of a pneumatic anti-shock garment, medications used for chronic conditions. It is dangerous to wait until the trauma patient fits a precise physiological classification of shock before initiating aggressive volume restoration. Fluid resuscitation must be initiated when early signs and symptoms of blood loss are apparent or suspected, not when the blood pressure is falling or absent. Class 1 hemorrhage up to 15%. Blood volume loss. The clinical symptoms of volume loss with class 1 hemorrhage are minimal. In uncomplicated situation, minimal tachycardia occurs. No measurable changes occur in blood pressure, pulse pressure, or respiratory rate. For otherwise healthy patients, this amount of blood loss does not require replacement, transcapillary refill, and other compensatory mechanisms restore blood volume within 24 hours. However, in the presence of other fluid changes, this amount of blood loss may produce clinical symptoms in which case replacement of The primary fluid losses corrects the circulatory state, usually without the need for blood transfusion. The next is class 2 hemorrhage, and about 15 to 30% of blood volume loss in a 70 kilos male. Volume loss with class 2 hemorrhage represents from 750 to 1,500 milliliters of blood. Clinical signs include tachycardia, heart rate about 100 in adult, tachypnoea, and decreased pulse pressure. The later signs is related primarily to a rise in the diastolic component due to increase in circulating catecholamines. These agents produce an increase in peripheral vascular tone and resistance. Systolic pressure changes minimally in early hemorrhagic shock, therefore it's important to evaluate pulse pressure rather than systolic pressure. Other pertinent clinical findings with this amount of blood loss include subtle CNS changes such as anxiety, flight, and hostility. Despite the significant blood loss and cardiovascular changes, urinary output is only mildly affected. The measured urine flow is usually 20 to 30 milliliters per hour in adult. Accompanying fluid losses can exaggerate the clinical manifestation of class 2 hemorrhage. Some of these patients may eventually require blood transfusion but may be stabilized initially with crystalloid solutions. Next is class 3 hemorrhage, and this hemorrhage is about 30 to 40% of blood volume loss. The blood loss with class 3 hemorrhage, approximately 2 liters in adult of blood, may be devastating. Patients almost always present with the classic signs of inadequate perfusion, including marked tachycardia and tachypnoea, significant changes in mental status, and a measurable fall in systolic pressure. In an uncomplicated case, this is the least amount of blood loss that consistently causes a drop in systolic pressure. Patients with this degree of blood loss almost always require transfusion. However, the priority of management is to stop the hemorrhage by emergency operation if necessary in order to decrease the need for transfusion. Class 4 hemorrhage is about more than 40% of blood volume loss. The degree of sanguination with class 4 hemorrhage is immediately life-threatening. Symptoms include marked tachycardia, significant decrease in systolic blood pressure, and a very narrow pulse pressure or an unobtainable diastolic pressure. Urinary output is negligible and mental status is markedly depressed. The skin is cold and pale. Patients with class 4 hemorrhage frequently require rapid transfusion and immediate surgical intervention. These decisions are based on the patient's response to the initial management techniques. Loss of more than 50% of blood volume results in loss of consciousness and decreased pulse and blood pressure. The clinical usefulness of this classification scheme is illustrated by following example. Because class 3 hemorrhage represents the smallest volume of blood loss that is consistently associated with a drop in systolic pressure. A 70 kilos patient with hypotension who arrives at the emergency department or trauma center has lost an estimated about 1,500 milliliters of blood. Non-response to fluid administration indicates persistent blood loss, unrecognized fluid losses, or non-hemorrhagic shock. Next is fluid changes secondary to soft tissue injury. Major soft tissue injuries and fractures compromise the hemodynamic status of injured patients in ways. First, blood is lost into the site of injury, particularly in cases of major fractures. For example, a fractured tibia or humerus may be associated with the loss of as much as 750 milliliters of blood. Twice that amount is commonly associated with femur fractures, and several liters of blood may accumulate in a retroperitoneal hematoma associated with a pelvic fracture. The second factor to be considered is the edema that occurs in injured soft tissues. The degree of this additional volume loss is related to the magnitude of the soft tissue injury. Tissue injury results in activation of a systemic inflammatory response and production and release of multiple cytokines. Many of these locally active hormones have profound effects on the vascular endothelium, which increases permeability. Tissue edema is a result of shifts in fluid primarily from the plasma into the extravascular, extracellular space. Such shifts produce an additional depletion in intravascular volume. Initial management of hemorrhagic shock. What can I do about shock? The diagnosis and treatment of shock must occur almost simultaneously. For most trauma patients, treatment is instituted as if the patient has hypovolemic shock, unless there is clear evidence that the shock state has a different cause. The basic management principles is to stop the bleeding and replace the volume loss. Physical examination. The physical examination is directed toward the immediate diagnosis of life-threatening injuries and includes assessment of the ABCDs. Baseline recordings are important to monitor the patient's response to therapy. Vital signs, urinary output, and level of consciousness are essential. A more detailed examination of the patient follows as the situation permits. Airway and breathing. Establishing a patient airway with adequate ventilation and oxygenation is the first priority. Supplementary oxygen is supplied to maintain oxygen saturation at greater than 95%. Circulation hemorrhage control. Priorities for the circulation include controlling obvious hemorrhage, obtaining adequate intravenous access, and assessing tissue perfusion. Bleeding from external wounds usually can be controlled by direct pressure to the bleeding side. A pass may be used to control bleeding from pelvic or lower extremity fractures, but its use should not interfere with the rapid establishment of intravascular volume by intravenous fluid infusion. The adequacy of tissue perfusion dictates the amount of fluid resuscitation required. Surgery may be required to control internal hemorrhage. Disability neurological examination. A brief neurological examination will determine the level of consciousness, eye motion, and pupillary response, best motor function, and degree of sensation. This information is useful in assessing cerebral perfusion, following the evaluation of neurologic disability, and predicting future recovery. Alteration of central nervous system function in patients who have hypertension as a result of hypovolemic shock do not necessarily imply direct intracranial injury and may reflect inadequate brain perfusion. Restoration of cerebral perfusion and oxygenation must be achieved before ascribing these findings to intracranial injury. Exposure complete examination. After life-saving, priorities are dressed, the patient must be completely undressed and carefully examined from head to toe to search for associated injuries. When undressing the patient, it's essential to prevent hypothermia. The use of fluid warmers as well as external passive and active warming techniques are essential to prevent hypothermia. Gastric dilation decompression. Gastric dilation often occurs in trauma patients, especially in children, and may cause unexplained hypotension or cardiac dysrhythmia, usually bradycardia from excessive vagal stimulation. In unconscious patients, gastric distension increases the risk of aspiration of gastric contents, which is a potentially fatal complication. Gastric decompression is accomplished by intubating the stomach with a tube passed nasally or orally and attaching it to suction to evacuate gastric contents. However, proper positioning of the tube does not completely obviate the risk of aspiration. Urinary catheterization. Blood catheterization allows for assessment of the urine for hematuria and continuous evaluation of renal perfusion by monitoring urinary output. Blood at the ureteral meatus or high riding mobile or non-palpable prostate in males is an absolute contraindication to the insertion of a transureteral catheter prior to radiographic confirmation of an intact ureter. Vascular access lines. Access to the vascular system must be obtained promptly. This is best done by inserting two large caliber minimum of 16 gauge peripheral intravenous catheter before placing a central venous line is considered. The rate of flow is proportional to the horsepower of the radius of the cannula and inversely related to its length. Hence, short, large caliber peripheral intravenous lines are preferred for the rapid infusion of large volumes of fluid. Fluid warmers and rapid infusion pumps are used in the presence of massive hemorrhage and severe hypotension. The most desirable sites for peripheral percutaneous intravenous line in adults are the forearms and antecubital veins. If circumstances prevent the use of peripheral veins, large caliber central venous, femoral, jugular, or subclavian vein assess using the Zelldinger technique or saphenous vein. Cut down is indicated depending on the skill and experience of the doctor. Frequently, in an emergency situation, central venous access is not accomplished under tightly controlled or completely sterile condition. These lines should be changed in a more controlled environment as soon as few patients' condition permits. Consideration also must be given to the potential for serious complications related to attempt central venous catheter placement, such as pneumothorax or hemothorax, in patients who may already be unstable. In children younger than 6 years, the placement of intraosseous needles should be attempted before inserting a central line. The important determination for selecting a procedure or route for establishing vascular access is the experience and skill of the doctor. Intraosseous access with specially designed equipment also is possible in adults. As intravenous lines are started, blood samples are drawn for type and cross-match appropriate laboratory analysis. Toxicology studies and pregnancy testing for all females of childbearing age. Arterial blood gas analysis is performed at this time. A chest X-ray must be obtained after attempts at inserting a subclavian or internal jugular CVP monitoring line to document the position of the line and to evaluate for a pneumothorax or hemothorax. Initial fluid therapy. Warmed isotonic electrolyte solutions such as Lactated ringers and normal saline are used for initial resuscitation. This type of fluid provides transient intravascular expansion and further stabilizes the vascular volume by replacing accompanying fluid losses into the interstitial and intercellular space. An alternative initial fluid is hypertonic saline, although there is no evidence of survival advantage in the current literature. An initial warm fluid bolus is given as rapidly as possible. The usual dose is 1 to 2 liters for adults and 20 liters per kilo for pediatric patients. This often requires application of pumping devices, mechanical or manual, to the fluid administration sets. The patient response is observed during this initial fluid administration, and further therapeutic and diagnostic decisions are based on this response. The amount of fluid and blood required for resuscitation is difficult to predict on initial evaluation of the patient. A rough guideline for the total amount of crystalloid volume required in the short term is to replace each 1 ml of blood loss with 3 ml of crystalloid liquid, thus allowing for its restitution of plasma volume lost into the interstitial and intercellular spaces. This is known as a 3-for-1 rule. It is most important to assess the patient's response to fluid resuscitation and evidence of adequate end-organ perfusion and oxygenation. And we can check it via urinary output, level of consciousness, and peripheral perfusion. If during resuscitation the amount of fluid required to restore or maintain adequate organ perfusion greatly exceeds this estimates, a careful reassessment of the situation and the search for unrecognized injuries and early causes of shock are necessary. The goal of resuscitation is to restore organ perfusion. This is accomplished by the use of resuscitation fluids to replace lost intravascular volume and guided by the goal of restoring a normal blood pressure. Note, however, that if blood pressure is raised rapidly before the hemorrhage has been definitively controlled, increased bleeding may occur. This can be seen in the small subset of patients in the transient or non-responder category. Persistent infusion of large volumes of fluids in an attempt to achieve a normal blood pressure is not a substitute for definitive control of bleeding. Fluid resuscitation and avoidance of hypotension are important principles in the initial management of blood trauma patients, particularly those with traumatic brain injury. In penetrating trauma with hemorrhage, delaying aggressive fluid resuscitation until definitive control may prevent additional bleeding. Although complications associated with resuscitation injury are undesirable, the alternative of exsanguination is even less so. A careful, balanced approach with frequent re-evaluation is required. Balancing the goal of organ perfusion with the risks of bleeding by accepting a lower than normal blood pressure has been termed controlled resuscitation, balanced resuscitation, hypotensive resuscitation, and permissive hypotension. The goal is the balance, not the hypotension. Such as resuscitation strategy may be a bright tool, but is not a substitute for definitive surgical control of bleeding. Evaluation of fluid resuscitation and organ perfusion. What is the patient response? The same signs and symptoms of inadequate perfusion that are used to diagnose shock are useful determinants of patient's response. The return of normal blood pressure, pulse and pulse rate are signs that suggest perfusion is returning to normal. However, these observations give no information regarding organ perfusion. Improvements in the CVP status and skin circulation are important evidence of enhanced perfusion but are difficult to quantitate. The volume of urinary output is a reasonable sensitive indicator of renal perfusion. Normal urine volumes generally imply adequate renal blood flow if not modified by the administration of diuretic agents. For this reason, urinary output is one of the prime monitors of resuscitation and patient response. Changes in CVP can provide useful information, and the risk incurred in placement of CVP line are justified for complex cases. Measurement of CVP is adequate for most cases. Urinary output. Within certain limits, urinary output is used to monitor renal blood flow. Adequate resuscitation volume replacement should produce a urinary output of approximately 0.5 milliliters by kilo by hour in adults. Various 1 milliliter per kilo in house is an adequate urinary output for pediatric patients. For children under 1 year of age, 2 milliliters by kilo by hour should be maintained. The inability to obtain urinary output at these levels or a decreasing urinary output with an increasing specific gravity suggests inadequate resuscitation. This situation should stimulate further volume replacement and diagnostic endeavors. Acid-base balance. Patients in early hypovolemic shock have respiratory alkalosis due to tachypnea. Respiratory alkalosis is frequently followed by mild metabolic acidosis in the early phases of shock and does not require treatment. Severe metabolic acidosis may develop from long-standing or severe shock. Metabolic acidosis is caused by anaerobic metabolism, which results from inadequate tissue perfusion and the production of lactic acid. Persistent acidosis is usually caused by inadequate resuscitation or ongoing blood loss, and in the normothermic patient in shock, it should be treated with fluids, blood, and consideration of operative intervention to control hemorrhage. Base deficit and or lactate can be useful in determining the presence and severity of shock. Serial measurement of these parameters can be used to monitor the response to therapy. Sodium bicarbonate should not be used routinely to treat metabolic acidosis secondary to hypovolemic shock. Therapeutic decisions based on response to initial fluid resuscitation. The patient's response to initial fluid resuscitation is key to determining subsequent therapy. Having established a preliminary diagnosis and treatment plan based on the initial evaluation, the doctor now modifies the plan based on the patient's response. Observing the response to initial resuscitation identifies patients whose blood loss was greater than estimated and whose with ongoing bleeding who require operative control of internal hemorrhage. Resuscitation in the operating room can accomplish simultaneously the direct control of bleeding by the surgeon and the restoration of intravascular volume. In addition, it limits the probability of overtransfusion or unnecessary transfusion of blood in patients whose initial status was disappropriate to the amount of blood loss. It is particularly important to distinguish patients who are hemodynamically stable from those who are hemodynamically normal. A hemodynamically stable patient may have persistent tachycardia, tachypnea, and oliguria, clearly under-resuscitated and still in shock. In contrast, a hemodynamically normal patient is one who exhibits no signs of inadequate tissue perfusion. The potential patterns of response to initial fluid administration can be divided into three groups: rapid response, transient response, and minimal or no response. Rapid response. Patients in this group, termed rapid responders, respond rapidly to the initial fluid bolus and remain hemodynamically normal after the initial fluid bolus has been given and the fluids are slowed to maintenance rates. Such patients usually have lost minimal less than 20% blood volume. No further fluid bolus or immediate blood administration is indicated for this group. Typed and cross-matched blood should be kept available. Surgical consultation and evaluation are necessary during initial assessment, and treatment as operative intervention may still be necessary. Transient response. Patients in the second group, termed transient responders, respond to the initial fluid bolus. However, they begin to show deterioration of perfusion indices as the initial fluids are slowed to maintenance levels, indicating either an ongoing blood loss or inadequate resuscitation. Most of these patients initially have lost an estimated 20% to 40% of their blood volume. Continued fluid administration and initiation of blood transfusion are indicated. Transient response to blood administration should identify patients who are still bleeding and require rapid surgical intervention. Minimal or no response. Failure to respond to crystalloid and blood administration in the emergency department dictates the need for immediate definitive intervention to control exsanguination hemorrhage. On very rare occasions, failure to respond may be due to pump failure as a result of blunt cardiac injury, cardiac tamponade, or tension pneumothorax. Non-hemorrhagic shock always should be considered as a diagnosis in this group of patients. CVP monitoring or cardiac ultrasonography helps to differentiate between the various causes of shock. Cross-match, type specific, and type 0 blood. The main purpose of blood transfusion is to restore ventilation carrying capacity of the intravascular volume. Volume resuscitation itself can be accomplished with crystalloids, with added advantage that it contributes to interstitial and intracellular volume restitution. Fully cross-matched blood is preferable. However, the complete cross-matching process requires approximately 1 hour in most blood banks. For patients who stabilize rapidly, cross-matched blood should be obtained and made available for transfusion when indicated. Type-specific blood can be provided by most blood banks within 10 minutes. Such blood is compatible with ABO and RH blood types, but incompatibilities of other antibodies may exist. Type-specific blood is preferred for patients who are transient responders as described in the previous section. If type-specific blood is required, complete cross-matching should be performed by the blood bank. Second type-specific blood is unavailable type 0 packed cells are indicated for patients with exsanguination hemorrhage. To avoid incitation and future complications, Rh-negative cells are preferred for fertile and of childbearing age. For life-threatening blood loss, the use of unmatched type-specific blood is preferred over type 0 blood. This is true unless multiple unidentified calculates are being treated simultaneously and the risk of inadvertently administering the wrong unit of blood to a patient is great. Warming fluids, plasma and crystalloid. Hypothermia must be prevented and reversed if a patient has hypothermia on arrival at the hospital. The use of blood warmer in the emergency department is desirable, even if cumbersome. The most efficient way to prevent hypothermia in any patient receiving massive volumes of crystalloid is to heat the fluid to 39 degrees before using it. This can be accomplished by storing crystalloids in a warmer or with the use of microwave oven. Blood products cannot be warmed in a microwave oven, but they can be heated by passage through intravenous fluid warmers. Autotransfusion. Adaptations of standard tube thoracostomy collection devices are commercially available. These allow for sterile collection, anticoagulation, generally with sodium citrate solution, not heparin, and retransfusion of the shed blood. Collection of shed blood for autotransfusion should be considered for any patient with a major hemothorax. Coagulopathy. Severe injury and hemorrhage result in the consumption of coagulation factors and early coagulopathy. Massive transfusion with the resultant dilution of platelets and clotting factors, along with the adverse effect of hypothermia on platelet aggregation and the clotting cascade, all contribute to coagulopathy in injured patients. Prothrombin time, partial thromboplastin time, and platelet count are valuable baseline students to obtain in the first hour. Especially if the patient has a history of coagulation disorders, takes medications that alter coagulation, for example, warfarin, aspirin, and non-steroid anti-inflammatory agents, drugs, or a reliable bleeding history cannot be obtained. Transfusion of platelets, cryoprecipitate, and fresh frozen plasma should be guided by these coagulation parameters, including fibrinogen levels. Routine use of such products is generally not warranted unless the patient has a known coagulation disorder or has undergone anticoagulation pharmacologically for management of a specific medical problem. In such cases, specific factors replacement therapy is immediately indicated when there is evidence of bleeding or the potential for acute blood loss exists, for example, head, abdominal, or thoracic injury. However, consideration of early blood component therapy should be given to patients with class 4 hemorrhage. Patients with major brain injury are particularly prone to coagulation abnormalities as a result of substances, especially tissue thromboplastin, that are released by damaged nerve tissue. These patients' coagulation parameters need to be closely monitored. Calcium administration. Most patients receiving blood transfusions do not need calcium supplements. Excessive supplemental calcium may be harmful. Special considerations in the diagnosis and treatment of shock. Special considerations in the diagnosis and treatment of shock include the mistaken equation of blood pressure with cardiac output, patient age, adolescent shock, pregnancy, patient medication, hypothermia, and the presence of pacemakers. Equating blood pressure with cardiac output. Treatment of hypovolemic or hemorrhagic shock requires correction of inadequate organ perfusion by increasing organ blood flow and tissue oxygenation. Increasing blood flow requires an increase in cardiac output. Ohm's law applied to cardiovascular physiology states that blood pressure is proportional to cardiac output and systemic vascular resistance. An increase in blood pressure should not be equated with a concomitant increase in cardiac output. An increase in peripheral resistance, example with vasopressor therapy with no change in cardiac output, results in increased blood pressure, but no improvement in tissue perfusion or oxygenation. Advanced age. Elderly trauma patients require special consideration. The aging process produces a relative decrease in sympathetic activity with respect to the cardiovascular system. This is thought to result from a deficit in the receptor response to catecholamines rather than from a reduction in catecholamine production. cardiac compliance decreases with age, and older patients are unable to increase heart rate or the efficiency of myocardial contraction when stressed by blood volume loss as a younger patient. Atherosclerotic vascular occlusive disease makes many vital organs extremely sensitive to even the slightest reduction in blood flow. Many elderly patients have pre-existing volume depletion resulting from long-term diuretics use or subtle malnutrition. For these reasons, hypotension secondary to blood loss is poorly tolerated by elderly trauma patients. Beta-adrenergic blockade may mask tachycardia as an early indicator of shock. Other medications may adversely affect the stress response to injury or block it completely. Because the therapeutic range for volume resuscitation is relatively narrow in elderly patients, it is prudent to consider early invasive monitoring as a means to avoid excessive or inadequate volume restoration. Reduction in pulmonary compliance, decrease in diffusion capacity, and general weakness of the muscles of respiration limit the ability of elderly patients to meet the increased demands for gas exchange imposed by injury. This compounds the cellular hypoxia already produced by reduction in local oxygen delivery. Glomerular and tubular senescence in the kidney reduce the ability of elderly patients to preserve volume in response to the release of stress hormones such as aldosterone, catecholamines, vasopressin, and cortisol. The kidney also is more susceptible to the effect of reduced blood flow and nephrotic agents such as drugs, contrast agents, and the toxic products of cellular destruction. For all of these reasons, mortality and morbidity rates increase directly with age and long-term health status for mild and moderately severe injuries. Despite the adverse effect of the aging process, comorbidities from pre-existing disease, and a general reduction in the physiologic reserve of pediatric patients, the majority of these patients may recover and return to their pre-injury status. Treatment begins with prompt, aggressive resuscitation and careful monitoring. Athletes. Vigorous athletic training routines change the cardiovascular dynamics of this group of patients. Blood volume may increase 50% to 20%, cardiac output sixfold, and stroke volume 50%, and the resting pulse can average 50. The ability of athletes' bodies to compensate for blood loss is truly remarkable. The usual responses to hypovolemia may not be manifested in the athletes even when significant blood loss has occurred. Pregnancy. Physiological material hypovolemia requires great blood loss to manifest perfusion abnormalities in the mother, which also may be reflected in decreased fetal perfusion. Medications. Better adrenergic receptors blockers and calcium channel blockers can significantly alter a patient's hemodynamic response to hemorrhage. Insulin overdosing may be responsible for hypoglycemia and may have contributed to the injury-producing event. Long-term diuretic therapy may explain unexpected hypokalemia, and NSAIDs may adversely affect platelet function. Hypothermia. Patients suffering from hypothermia and hemorrhagic shock do not respond normally to the administration of blood and fluid. Resuscitation, mild coagulopathy often develops. Body temperature is an important vital sign to monitoring during the initial assessment phase. Esophageal or bladder temperature is an accurate clinical measurement of the core temperature. A trauma victim under the influence of alcohol and exposed to cold temperature extremes is more likely to have hypothermia as a result of vasodilatation. Rapid rewarming in an environment with a appropriate external warming devices, be it lamps, thermal caps, heat respiratory gases, and warm intravenous fluids and blood will generally prevent hypotension and hypothermia. Core warming may occasionally be indicated. Hypothermia is best treated by prevention. Pacemaker. Patients with pacemakers are unable to respond to blood loss in the expected fashion because cardiac output is directly related to heart rate. In the significant number of patients with myocardial conduction defects who have such devices in place, CVP monitoring is invaluable to guide fluid therapy. Reassessing patient's response and avoiding complications. Inadequate volume replacement is the most common complication of hemorrhagic shock. Immediate, appropriate, and aggressive therapy that restores organ perfusion minimizes these problematic events. Continued hemorrhage. Obscure hemorrhage is the most common cause of poor response to fluid therapy. Patients with this condition are generally included in the transient response category as defined previously. Immediate surgical intervention may be necessary. Fluid overload and CVP monitoring. After a patient initial assessment and treatment have been completed, the risk of fluid overload is minimized by careful monitoring. Remember, the goal of therapy is restoration of organ perfusion and adequate tissue oxygenation confirmed by appropriate urinary output, sinus function, skin color, and return of pulse and blood pressure toward normal. Monitoring the response to resuscitation is best accomplished for some patients in an environment in which sophisticated techniques are used. Early transfer of the patient to an intensive care unit should be considered for elderly patients and patients with non-hemorrhagic causes of shock. CVP monitoring is a relatively simple procedure used as a standard guide for assessing the ability of the right side of the heart to accept the fluid load. Properly interpreted and the response of the CVP to fluid administration helps evaluate volume replacement. Several points to remember are: first, the precise measure of cardiac function is the relationship between ventricular and diastolic volume and stroke volume. Right atrial pressure and cardiac output, as reflected by evidence of perfusion or blood pressure, or even by direct measurement, are indirect and, at best, insensitive estimates of this relationship. Remember these facts is important to avoid our dependency on CVP monitoring. Second, the initial CVP level and actual blood volume are not necessarily related. The initial CVP is sometimes high, even with a significant volume deficit, especially in patients with chronic obstructive pulmonary disease, generalized vasoconstriction, and rapid fluid replacement. The initial venous pressure also may be high because of the application of PSG or the inappropriate use of exogenous vasopressors. A minimal rise in the initially low CVP with fluid therapy suggests the need for further volume expansion, minimal or no response to fluid resuscitation category. A declining CVP suggests ongoing fluid loss and the need for additional fluid or blood replacement. Transient response to fluid resuscitation category. Fifth, an abrupt or persistent elevation in CVP suggests that volume replacement is adequate or too rapid or that cardiac function is compromised. Sixth, pronounced elevation of CVP may be caused by hypervolemia as a result of overtransfusion, cardiac dysfunction, cardiac tamponade, or increased intrathoracic pressure from a tension pneumothorax. Catheter malposition may produce erroneously high CVP measurements. Aseptic techniques must be used when central venous lines are placed. Multiple sites provide access to central circulation, and the decision regarding which route to use is determined by the skill and experience of the doctor. Ideal position for the tip of the catheter is the superior vena cava just proximal to the right atrium. Recognition of other problems. The placement of central venous lines carries the risk of potentially life-threatening complications. Infection, vascular injury, nerve injury, embolization, thrombosis, and pneumothorax may result. CVP monitoring reflects right heart function. It may not be representative of left heart function in patients with primary myocardial dysfunction or abnormal pulmonary circulation. When a patient fails to respond to therapy, consider cardiac tamponade, tension, pneumothorax, ventilatory problems, unrecognized fluid loss, acute gastric distension, myocardial infarction, diabetic acidosis, hypoadrenalism, and neurogenic shock. Constant re-evaluation, especially when patients' conditions deviate from expected patterns, is the key to recognition such problems as early as possible. Thank you for your attention.